Happy TB Day. Obviously, 1 hour will not be enough to do any justice to everything important regarding TB diagnosis and management, so I'll rather try and give you a broad South African overview. I'll aim this talk at clinicians, at students, at specialists, at pharmacists, nurses, lab professionals, everyone, any healthcare worker. So I hope that everyone will find something useful in my talk, and it will help everyone to achieve better TB prevention, better diagnosis and management wherever you work. So let's get right into it. I have no relevant financial conflicts of interest. All the product names that I used are for clinical familiarity only, so that we're all clear about what platforms, what antibiotics, products, and assays we are talking about. So importantly, you have to always know what's available in your local setting, and then to keep this in mind and to always, when you contextualize any so-called evidence into your own local practice. So, yes. So this is not a picture of someone busy dying of tuberculosis. It is a picture from a silent film from Germany, and from 100 years ago, and it was based on the novel by Bram Stoker called Dracula. Now, there have been many different iterations and interpretations of this novel over the years. There have been many stories about vampires. There's been this famous Dracula movie almost 35 years ago. And at the moment, there's a classic ballet in Cape Town Artscape, also called Dracula. So why do I mention this? Why do I mention TB specifically today? So the reason why we have vampires and all the myths about vampires is that the Europeans, in 16 to 1800s, about 25% of all deaths were due to TB in Europe and Middle East. And in the Middle East, they call it a consumption. They call it sometimes the White Death, and they didn't call it the White Death because it was spread over the world by Europeans, but because they were so pale and they were anemic and hectic, and the bodies consumed themselves. And the vampire myths was more a hereditary interpretation or a spiritual interpretation of what was going on, because they didn't know about infectious diseases. They would thought that when the first person in a household dies of TB, they may come back later as a vampire and suck the life and the blood out of the other people of the household. So they really had no idea about infectious diseases. So TB Day today is the 24th of March, and that is because on 24th of March of 1882, Robert Koch announced his discovery of the tuberculosis, and he proved that tuberculosis is caused by an infectious organism. And this was a major scientific breakthrough, and it was the first time we realized that TB was established now as an infectious disease. It was not hereditary, and it laid the foundation for what later became known as Koch's postulates. So, and this forms the foundation of modern infectious diseases. He later received a Nobel Prize for that. And in the picture there, he was actually in South Africa for a few months, and he worked on a disease that someone can type it in the comments, but it was only the second disease that was ever wiped off the earth. It was declared eradicated back in 2011 by WHO. So he worked on that disease, and he actually devised the anti-sera at that time in Kimberley. So the World TB Day message is, we have this TB message every year since 2020, and then it's yes, we can end TB. And the WHO always tells us how many people's lives were saved. They tell us how many people fell ill in the previous year and how many people died from TB. And it's an awareness campaign as well. So the United Nations had various goals towards TB, combating TB over the years, but the targets have never really been met. So it's usually not met by a massive margin. So, for example, globally, the net reduction in TB incidents from 2015 to 2024 was only 12.3%, and that's far from the WHO end TB strategy milestone of 50% by 2025. So at the moment, we're working towards the United Nations Sustainable Development Goals, and that they were updated in 2015, and it's from a period of 2015 to 2030, and on top of that, end TB strategy of WHO for 2035. This was all launched in 2014. So our strategic plan in South Africa is well aligned with the WHO and the United Nations Sustainable Development Goals, and it includes a strong commitment towards ending TB by 2035. The TB is still today in 10th place when it comes to top causes of death. That's worldwide, and worldwide, only a minority of TB deaths occur in the HIV population. Of the estimated 10.7 million people who fell ill with TB in 2024, only 5.8% were among people with HIV. And then for Africa specifically, we can see over the last 15 years, the HIV or the mortality rate per 100,000 dropped sharply, especially in HIV-positive population. So Africa has about 25% of the world's TB cases, but only about 15% of the world's population. You can see this in 2024, we had 8.13 billion people globally, and 2.6 billion were from 2.6 million cases were from African region, and which by far the most, except maybe it's close to the Southeast Asia region. But the main difference in Africa is that we have 10 times more people with HIV. The rate of people living with HIV as well is 10 times more than any other region globally. So all the incidence rate in TB in South Africa are below the 2025 milestone, but the number of deaths are still far above the target, and it's not declining fast enough. And if you look at drug-resistant TB globally, then the estimated number of people who developed drug-resistant TB specifically has been falling steadily since 2015, from about 1/3 less than in 2015, 10 years ago. But if you look at South Africa, with drug-resistant TB, we only dropped in the same period about 25% less cases per year. And we also see the number of new cases are dropping very slowly, but those that had drug-resistant TB, the new drug, they drop slowly. But if you had TB before, that's even on increase at the moment. So that's getting worse. So our South African National TB Recovery Plan that ends end of this month, so it rightfully includes HIV in its approach, and we say we've made notable progress since 2015, about 57% decreased incidence of the TB rate, and the coverage of treatment has covered about 79%. However, the TB-related deaths have only declined by 16%. So we have had significant efforts to restore our services since the COVID-19 pandemic. And in 2024, we aimed for 3 million, to do 3 million TB PCR tests. And we didn't aim, we almost got 3 million, 2.99 million tests were done. We can see that over the last 10 years, there was a drop in the TB mortality rate for HIV, for TB in the HIV-positive population, and it dropped sharply before that, even when ARVs were instituted. So in October last year, the Minister of Health announced that we have this very fancy TB dashboard. It's accessible to anyone in the public, and you can go and look at how many tests were done. At the moment, as of today, we have done in South Africa just over 3 million tests, and our target by end of this month for the last 12 months was 5 million. So yeah, we have only reached 60% of the target. We can also clearly see from this data, for instance, so this data is there to help each district to budget and to target the correct people to be tested. You can see many more women are being tested, and proportionally many more men are testing positive, for instance. And you can see, you can go down different districts and look at that. And then in February this year, from the Tembisa group, they also published their own dashboard. This is more on modeled estimates of data they have. And what's good about this is you can generate your own graphs, and you can download all these the stats yourself, and it includes specifically HIV as well. So you can look at both HIV, TB and HIV specifically. Now they also make a point in one of the studies that come from the group that lower health seeking rates in males accounted for a 7% higher mortality rate in men. That's why men are targeted more nowadays for this. And then some of the provinces even have their own TB dashboard. Everyone's making dashboards now of the data. And yeah, so I assume other provinces may also have that. Just a word on the funding cuts. South Africa's US aid funding cuts from last year, everyone's very worried about that. And there was some analysis done that if there was no recovery funding over the next 5 years, how many more people will contract TB, how many more people will die from TB, if the recovery is within 1 year or in 3 months. Different estimates, they're all quite terrible actually. But South Africa is graded as a low dependency country, where the study said to be 21.1% of our funding comes from the US aid for TB. But many of our, like Zimbabwe and Mozambique, are high dependency countries, and they are our neighbors, so that will affect us as well. Our own government's figures put the figure at 14.5%, not 21%. This is according to our own TB recovery plan. And then we have, there's a source of confusion in TB is all the different guidelines that you have, and all of them answer different questions, overlapping questions, all the two sort of legacy guidelines from 2014 and 2015. Much of that still applies and still used. We are really waiting for a new 2014, a new TB management guideline for adults. In 2024, there was really a very good guideline was published for children with TB. In 2023, the MDR treatment with drug-resistant TB guideline was published. And yeah, to put all this together is not easy. And to make it worse, WHO guidelines, they have even more. They have guidelines and handbooks. And what they have actually done recently, and thankfully, is they have combined and consolidated many of the guidelines. For instance, all of these documents and guidelines went to this deal of operational handbook and guidelines for rapid diagnostics. So they've created all the myriad of documents. They created 6 modules. In each module, for instance, module 3 is on diagnosis. There's a consolidated guideline and operational handbook. So that really helps us all a lot. And within those, you have different chapters. Say chapter 1 is for drug acceptable, chapter 2 for drug resistant, TB, and so forth. Stepping away from the guidelines now. So it's important to note the difference between pulmonary and extrapulmonary tuberculosis. And extrapulmonary is for all the organs in general that are not the lungs, so not the lung parenchymal lesions. So in HIV, or in HIV immunocompetent people, 80% is normally just in the lungs, pulmonary TB, and about 20% has an extrapulmonary component, and extrapulmonary is most of the time it's either pleural effusion or lymph nodes, and then all these others. But in immunocompromised individuals, the extrapulmonary component is there's about 70% of them have extrapulmonary as well, or exclusively only 20%. And so this have a extrapulmonary. The problem is it's often paucibacillary, and you have to really approach these sample taking very differently. You have to often send in more samples, more tests just to identify the TB or the DNA in there. Another concept that's important is the distinction between those that are performed directly on a specimen and those that are performed after you first culture to isolate. So direct testing, usually molecular testing, is fast, and it allows us to detect TB and sometimes resistance markers within hours. That speed is essential for early treatment decisions, but culture-based testing takes longer, unfortunately, and however, it provides more information. It confirms that whatever we get is viable, it's live organisms. It's not dead DNA from an old infection or a treated infection. It's really still alive. And from the live bacteria, you can do many more tests. You can do full phenotypic drug susceptibility testing and various surveillance studies, investigations. So in practice, direct testing guide initial clinical decision, but it's always followed up with culture-based testing. Or most of the time, it should be to confirm the full resistance profile, unless it's clearly no resistance. It is also important to understand there's a difference when we talk about the lab results between discordant and discrepant. They're not the same. So discrepant is easy to understand. It simply is the results are different, and you expect it to agree with each other, but it does not. And that normally needs a full investigation. Pre-analytical analytical processes, something went wrong somewhere. But discordance, on the other hand, is really fully expected in living organisms. We tend to see discordance more when we increase the number of tests, when we test different anatomical sites, and as our testing becomes more sensitive. It really is. It refers to the normal, natural, biological variability in living organisms. So various studies, including some excellent South African studies, have been conducted over years that have looked at and described these concepts of potential genetic diversity and mixed infections. But I think this study was still one of the most eye-opening studies for me. So the investigators had 44 subjects in KZN. There were post-mortems, and they collected 2,693 samples from them and did all sorts of investigations. And they found that there was a huge diversity and within individuals that coexisted probably within people for many years, different sublineages and distinct strains with mixed infections. They were often not in different organs even, but differentially distributed within the same lung. So as a consequence, they said samples taken from the upper airway often captured only a fraction of the population diversity, challenging current methods of outbreak tracking and resistance diagnostics. So that's why our tests don't often, there's so much discordance. And just quickly about discordance, it's very difficult and costly to differentiate whether a patient was infected with more than one strain, because it's a chronic disease. Over a long time, it can be infected many times over, or if the variability is due to just normal evolution of the bacteria. Either way, the patient then ends up with a heterogeneous infection. And this may or may not also include different antibiograms when you test them. So when talking about resistance in this context, it's useful to refer to this phenomenon as heteroresistance. Some people talk about macro and micro heteroresistance. There's obviously different degrees of heteroresistance. And when and this has an effect on both on how we should interpret tests and on patient management. These so-called degrees of heteroresistance has unfortunately not been exhaustively researched and described specifically for TB. And many of the molecular platforms have very wide limit of detection ranges for different targets, even within the same assay. So the take-home message is probably that most routine diagnostics will miss minority resistant populations if it's less than 10 to 20%, except maybe for phenotypic proportion method drug susceptibility testing and certain targeted or deep sequencing techniques. As a rule of thumb, you need about 20 to 40% of the bacteria in a sample to be resistant before the target will be picked up by our most routine methods. So heteroresistance can often be systematically detected, and that is why it's very important to not test once, but to send in multiple samples. And then in the end, it's the safest option normally to treat the most resistant antibody parameter you get, according to that. So this is just to say the importance of radiology is still, chest x-rays are especially remain central. I got these pictures from the knowledge translation unit. They have excellent guides that you can download for free. You have to register first when they call the packed adult guidelines. It's a pediatric guide as well. And it's a big 170-80 page PDF, and it got all the flow diagrams really translated in simple language and still very comprehensive for TB and for all sorts of medical conditions. They translate all our guidelines that we have. And this one, the pediatric one, is for 2026, and they say it's for the Western Cape, but I'm sure it will work in just as well many other places. And radiology in children is you have to differentiate between severe and non-severe, and that's can be quite tricky. And there's a lot of data and guidance on that. This is a famous paper in that regard that you can go and have a look at. Next, histology is often useful to identify typical granulomas, and it's useful for TB ZN staining. You can do a PCR sometimes on histology specimens, but the sensitivity is not good. That's really should be last on the list. It's also important. Histology is also important to rule out alternative diagnoses. So when TB is strongly suspected, you must still rule out other diagnoses. So while it can support the diagnosis of TB, it's not organism specific. It can be a MOT or NTM as well, or various other things. Granulomas and caseous necrosis, like was put in this displayed in this picture, are highly suggestive in a correct clinical context, but it's not unique to TB. There are many other reasons for caseated granulomas, especially the fungal ones, and there's many causes for non-caseated granulomas. Importantly, early TB as well can give you non-caseating, so it's not so clear. AFVs may be absent here. There's no antibiogram, so you must still do molecular testing and culture. And just to say that when you, for instance, do a fine needle aspirate, it's important to rinse after you've made a slide, to rinse the needle, a syringe with saline in a separate container, and ask for cytology. Maybe there's lymphoma. You don't want to have to go back and look for lymphoma later. That can easily catch you out. ADA is part of the building blocks of DNA. And when you have high turnover state. We have a lot of production of cells dying. There's a lot of extra adenosine. Then you need adenosine deaminase, the enzyme, to break it down into uric acid to go through the kidneys. And so what ADA actually just tells you, there's a lot of activated T cells. So you have to ask, why do you want to just know about T cells? You know, T cells are very common in TB infections in those areas. Why do you want to look at that? Why not simply look for TB itself? It is because this test is very much used. It's useful in extrapulmonary TB, specifically in fluids. We don't have much TB. It's bacillary, so now you want to see if there may be an immune response. That can be useful. There are different, over the years, many different cutoff values for TB meningitis. That's a big problem to diagnose. The thing is, it's very difficult to compare studies because we often don't know what is the gold standard. Do you compare it to PCR or culture? All of them have very low sensitivity. So you don't know what is the gold standard to test any test against. And various different cutoffs have been used. We've gone in South Africa from 6, and then we had a paper about 2, and then international papers still mention 10 international units as the cutoff. This is a very interesting nomogram, quite useful. It talks about the pre-test and the post-test probability. So when you put a ruler here and you say, oh, let's flip a coin, we don't know, it's 50% chance pre-test that the patient got TBM. And then you make a line here, and you've got a result of 10, then you know the post-test probability is 90%. So if you maybe put it on 50 and you go to 2, it's about 75%. It's still high, it's the post-test probability, so it's somewhere between 95%. So the values are very close by. Next, we have to talk about Zn and auramine. So in general, auramine is still at least 10% more sensitive. It's not accurate, 100% accurate what I'm saying there, because we know, firstly, the limit of detection of a Zn is 10-fold lower than for a auramine. And auramine is much faster to do, but it's basically because you can zoom out when you do an auramine, so you can cover a much bigger area, surface area, when you search for this. So importantly is to know that concentration improves yield. Most labs, if you send in for TB microscopy, most labs, smaller labs especially, will do the Zil-Nielsen stain, not an auramine. You need some extra equipment for that. So they won't be able to do that. And then, so if you and small labs will not concentrate sputums. It's quite dangerous for lab personnel. They only do it in dedicated TB labs, and there you can concentrate it, you can auramine. So there's always a little bit less sensitivity when you do a Zn, but that's okay. It's more used as a screening tool. The point is not to rely on a Zn as a diagnosis, to always rely on other testing as well, and to know about these limitations. And the main use of this microscopy is to know about the bacillary burden. It's not for a full diagnosis, it's for bacillary burden when you follow up patients to see how they're doing, like responding to the medication. And to confuse matters, there's been like this for a long time when you talk about Zn staining and reporting auramine staining. What you see on a microscope on both sides is very different. 1 plus on this side is not the same as 1 plus on that side. It always creates confusion inside labs and outside labs for interpreting these. So you have to be aware about, if you say a 3 plus and then next time is 2 plus, it doesn't really mean that much is still positive. Now let's jump to the NHI's workflow, because the vast majority of our resistance TB cases, they are going identified in the public sector, and almost all of them are followed up in the public sector as well. So the first line test testing is always a rapid molecular testing. Smear microscopy is no longer the entry point for a long time, actually. So the rifampicin is the resistance is the key trigger point. It really changes both the testing pathway and the treatment pathway. And downstream from that, phenotypic drug susceptibility testing still remain important, especially for confirmation, also for expansion of resistance, profiling, surveillance. So you collect the seconds. So after you have either INH or RIF resistance, you collect the second specimen. In some provinces, they collect both from the get-go, and then one of them, quite excitingly, nowadays, since September last year at least, they go for targeted next generation sequencing. And yeah, that's quite an advanced testing. We get to that, and a part of it, and also a gene expert and midget culture and microscopy. And according to that, so all the RIF resistant examples get a smear next an XDR cartridge, and they get phenotypic drug susceptibility testing for bedaquiline, for linezolid, and for pertomanate. And if INH test susceptible for some reason, then they will get INH testing as well. Pertomanate testing is only done at the NIC, the National TB Reference Lab. Okay, so additionally to this, there are certain groups of patients where the reflex culture is also done on a second sample. That's especially when a TB PCR is negative. That is in pediatrics and extrapulmonary sites, and if you had previous TB in the last 2 years, and that this must be clearly documented on the form. Okay. So just a quick platform overview. Nowadays have the Roche Cobas in big labs and in smaller labs, the BD-Max, and then the experts in many different labs, big and small. We have different other platforms and kits from Elite, from Hein, Onnebroeker, and they all answer sort of different questions, but there's a lot of overlap as well. So these platforms should not be viewed as interchangeable competitors, but just they are there for different workflows. So let me see how that is the BD-Max there. The one we know very well is the Gene Expert, and we get the Gene Expert formula very small. It can only take 2 cartridges up to some of these can go up to 2,000 tests per day. And interestingly, this is called the Gene Expert Edge. It has this touch screen and a battery pack, mobile battery pack, and people go, it's a mobile unit. We are going one at a time. And I thought we would, like in this study, very interesting. They went to people's homes to do point of care testing. And they would test tongue swabs. And I wonder how long will it take to test 5 people's tongue swabs? But actually what they did was very clever. They test all of them at the same time in the same cartridge. And of course, if it's positive, then you have to test everyone. But in general, most of them were tested negative. And while they wait for the test to run, they do all sort of other healthcare interventions. The problem with the expert is always the trace comment. So in the CID this month, Caitlin Visek published this paper where they looked in 2 different high burden clinical settings, and they compared, they look at how the ultra trace results were performing there, and they said that the common practice that trace should be seen as maybe a false positive in HIV negative adults, or a false positive if they are they have completed TB treatment in the last 5 years. It's not good. So I mean, many labs already would not send out results as trace. They would rather send out as a low positive. And that is just because this trace name is very unique to GeneXpert. Other platforms don't use trace. It just indicates low bacillary load. And from this study and a comment on this study, the recommendations is that if you have a HIV positive patient, then a trace should be treated as active TB. If the patient is HIV negative, but there may be delays with the follow-up or poor follow-up, then rather start treatment as well. But if the patient is high HIV negative and low risk and has a reliable follow-up process in place, then rather repeat the testing, and you can monitor, and you can maybe wait. But in general, in South Africa, it's better to use most of the time trace, as simply mean it is positive. So the machine calls it trace when it identified that the two insertion sequences, but not the RPOB gene. On this table, we look at the Ultra, VDMax, and Roche. What's interesting here is that most labs will use only, NHS at least, will only use the expert for extrapulmonary specimens by and large. But it's important to know you can actually validate any instrument if you have enough samples and to run any specimen type. The big difference between the Ultra and the BD Max that we get everywhere is that the Ultra only talk about RPO, rifampicin resistance, but the BD Max and the Roche can look for INH, low-level, high-level resistance genes as well. An interesting differentiation also is that you see the limit of detection for rifampicin with the Ultra is very high compared to rifampicin in the BD Max. And one would think maybe that is the reason why the trace comment comes up so often. But these figures are from WHO documents and from the companies themselves. Another important caveat to know is that there are many studies compare these, but these different products as platforms, but it's hard to know what volume of sputum or specimen we used. The GeneXpert are well known. We can even put 0.5 ml sample and just add sample reagent to make it up to 2 ml, so 2 ml can be loaded. But with the others, it seems like you need more specimen. And that's not very clear. So when you compare these instruments, it's quite hard, because how do you really measure sputum, sticky bit of fluid in a specimen container? How do you really measure the volume of that? Maybe with a scale or something, but that's quite hard, and it's a caveat. So this was interesting. A study came out this year where the authors compared GeneXpert on plain sputum and with BD Max on plain sputum. Also, then they centrifuged it and concentrated and tested the pellet. And when you just look at the sensitivity, the GeneXpert actually did better, whether they look at all the results or excluded the trace or the HIV positive patients. Only in the HIV negative patients where the BD Max on the neat sputum did better. And interestingly, the BD Max between the neat sputum and its pellet, I think something went wrong with the method here, or something, but it was always lower when you use a pellet instead of the raw sputum. So that's when the authors concluded that although the BD Max assay demonstrated strong agreement with the expert, it identified fewer cases. So it really depends on your local lab how well they have validated the test for their patient population. You can't extrapolate really. So the Hain line prep assays, maybe I shouldn't spend too much time on them because they're being phased out. They have been phased out many places, but they are they were the first WHO recommended testing for in 2008 for drugs for rifampicin INH testing, and they've been used globally around the country as well, and is well known. We have these strips. So the genotype are all line probe assays. We read these strips. You can have an automated reader, but you still have to interpret it afterwards. A human have to check it as well. So the line probe assays, I won't talk about the MOTS and the others, but just at the top here, we have the DR plus and the second line drugs. So this is just for normal MDR TB. We look for rifampicin, isoniazid, and then the second line, we look for fluoroquinolones, second line injectable drugs. And they are often used as a reflex testing. If we have resistance here, then you do the second one. But now from Haynes, we also have the fluorotype. We have the MTB-DR, and this is now a test that is done. It's not done on the strip, but on a fluorocycler. So you look at graphs and that. And this can be quite high throughput. You can test up to 94 samples in 5.5 hours. You can test directly on specimen, on decontaminated specimen, on cultures, and give you also lots of mutation level information. So you can test up to 45 mutations of genes in a single PCR well. So this is the DR plus. This is how the results will look. For instance, then you can see for INH, there was in the promoter region, there's a mutation from thymine to adenine, and that constitutes INHA mutation and resistance. And you can look at the graphs, that's how it looks, not those strips. So this is the DR. And then you have the liquid array for the XDR antibiotics to test for them. So I won't talk about that. So the targeted next generation sequencing is somewhere between line prep assays and whole genome sequencing. So it's more comprehensive, but it's then line prep assays, but it's also faster and more practical than whole genome sequencing, and it's been optimized for clinical resistance detection and maybe for some form of epidemiology and outbreak investigations as well. So the WHO, they published the document on rapid communication and
Hi everyone, please just give us a few seconds. We will fix the sound just now.
please let me know when I can continue.
You can continue now. Please just reshare your screen, Doctor.
Reshare.
Yes, please.
Can you see it now?
No, I can't see it on my side.
Okay. Is that okay?
Yes, you can see it now.
Okay, thank you. So I'll continue. The important to know is a range between sensitivity and specificity. And as mentioned before, it works on both culture colonies and on clinical specimens. So the results, these like donut reports, are very visual and they're detailed and they carry a lot of information, and it's structured in such a way that you can, that it experienced reader can almost instantly see common strains and patterns. It's very interesting to go through these. We won't have time for that. TB culture is still important. Despite the rapid expansion of molecular testing, you still have to know, is the organism viable? You need it for certain phenotypic testing, like predominant, you can't do any other way. Podaculin is also important for to test podaculin through culture. And it's really, if you look at the long regimen for drug-resistant TB, then this is also quite important. But it is slow, it is contamination prone, and it can take a long, long time. When it's positive, then you do further testing, antigen testing, microscopy to see what is positive. This was an interesting study where people tried to do something about all the contamination in the midget, the microbacterial growth inhibitory tubes, indicator tube, and then when it's positive, then I would do a gene expert on that, and it made a huge difference in the turnaround time. Instead of waiting for a second specimen to submit it and doing the whole thing, they would just do a gene expert. Yeah, and that was quite a clever study. Blood cultures, that's done. It's very niche. It's more for, when you think about disseminated TB, it's not a routine TB test, but it is definitely available and it's combined with various other testing to actually find the bacteria. Urine LAM is become a very useful test as a non-sputum diagnostic tool in specific patient groups. Its highest value is in people living with HIV, especially very ill patients and inpatients. But the guidelines say that even for inpatients, with HIV, you don't have to wait. You don't have to suspect TB or look at the CD4 count or think a patient needs to be have advanced HIV before you test. You can really screen all inpatients with people who are living with HIV. So this is urine LAM is always a rapid rule-in adjunct because it's not very susceptible. We had this. We were very excited at one point because this was this Japanese LAM test that came in, and it initially showed to be a 30-fold lower limit of detection, but then some investigations showed that there was a lot of variability between the testing lots. So that didn't go anywhere. And we know this is just a recent study, but the sensitivity is around 45% and specificity is fairly high. There are many next generation urine LAM tests in the pipeline. None of them are commercial. Unfortunately, it's not a simple test. You need a lot of more expertise, but it is something that is promising and is on the horizon, and it's coming. So some of them are being investigated in South Africa as well, and I've had quite good outcomes so far. But to make it simpler, that will be the point. Otherwise, it's not a point of care test. So this study was published end of last year. Now it's was also interesting. It was in the Eastern Cape, and they tried to see what happened if they, on top of the urine LAM, they do a gene expert ultra as well on urine now, and it increased the yield quite a lot. the gene expert had a yield of 68% of the time, was positive, and the urine lamb was 45% of the time. And this is in definitive TB. So, but that is quite costly, and I think we hopefully we wouldn't have to use the ultra in this way, but because we have the urine test, so there's really scope to improve urine testing. If I look at this study correctly, I won't go into mento testing. There's been a lot of confusion sometimes between what cutoffs to use in what patients. The top is our African guidelines, and all these nice pictures are from the CDC. They want to be very sure, so they want to avoid false positives. So they have for people otherwise healthy, they want a very big zone of induration. But I mean, in the end, the African policy has changed now from latent TB infection to TB preventative treatment. So previously we focus on testing so we can treat, and now we focus on the risk management. So you look at what patients are at risk, and then you exclude TB from them, and then you treat them. You don't often test in this paradigm. So the implication is that tuberculosis skin testing is no longer a gatekeeper test. There is some value it can add in specific groups. For instance, in HIV negative patients older than 5 years who are exposed to TB, and do that typical use would be before you commit to TPT. It was previously called IPT. Now it's so it's now TPT. Before you commit to that, then you maybe can test the household contacts to look for 10 millimeter cutoff. When it should be actively discouraged is if it's going to delay TPT, TB preventative treatment. Or it should be actively discouraged if you want to exclude TB disease. That's not what it's for. It doesn't do that. And also in immunocompromised patients, there are too many false negatives, and routine use in adults in high burden settings should also be discouraged. It's more for low burden, endemic settings that may still use this. Interferon gamma release assays, we have the quantiferon gold and a TB spot. These tests, they don't test for TB, they test for TB infection, but they do not differentiate between active and latent infection. So they are useful as only selected TPT workup. So they are the point is that it detects immune memory but not active disease, and it's not really affected by BCG vaccinations, like they have that complication with mento testing. So in private practice, people use this often because you see TB recurring in people on biologics. Now, something that's a bit newer is the ERISA TB, is the interferon gamma rapid immunosuspension assay. It doesn't look for interferon gamma. It looks for unstimulated interferon gamma in body fluid specifically. So specifically in the pleural, CSF, pericardial, and ascites fluids. It's more a rule-in test for certain types of extrapulmonary TB. And it results according to the package insert is that it's available in 2 hours. It's got very high sensitivity and specificity. It's not difficult. There's a quite easy sample preparation. There's a few studies, and it's a proudly South African product as far as I can tell. So it'll be interesting to see as more studies come out how well this test does. But it's quite exciting, especially in the context of maybe meningitis, TB meningitis, that could be quite useful. Now, I won't go into detail about the old 10-year-old drug susceptibility TB guideline. We all know it. It's very well. Maybe just to say that In the drugs that we have, the changing of the name is quite problematic. In private practice, many of the retail pharmacies, they do not know about Ringtip and Afaris and Afaris. They talk about, they know about Riva 4 and Refina, but those are not really available anymore. So patients get diagnosed with drug-susceptible TB, they go to various places, and then all across the city, they're looking for the pharmacies to get these drugs. No one can give it to them. In the end, they have to go through the government sector, even though it should be available. So yeah, if you look, there are quite a few drugs available. These are the ones that I'm familiar with here, but some of the others may also be available. So it's important to monitor drug-susceptible TB at the right time. For instance, the end of the intensive phase, end of the first 2 months, then you see if that's still smear positive, maybe extend, and then at the end of treatment, you do that again. So if we just jump to the resistant TB guidelines, there were many changes over the last 10 years. So before 2016, we still had the long 18, 24-month treatment regimens. And then in 2016, it changed. The WHO had an update, and there were some 9-month regimens. And then 4 years later, there was the 9-month regimens without any injectables. And in 2022, the 6-month BPAL regimens came out. And South Africa also, just the next year, it was rolled out, the BPAL and BPAL-L regimens. So that was very quick, very exciting. It's a very good guideline, that. And there was a lot of marketing at the time. It is they almost ask patients to go and see if they can find this. When there's only 23 pills per week, only 6 months, and it's really a game changer. This. So so it's a short, all oral regimens. They are now central. So the long regimens are no longer dominant. These regimens are for specific people, and if you're not in that group, then you go for longer. Then you have to go for longer regimens. Okay, I'll get to that. We'll get what, but it's really all driven by rapid drug susceptibility testing. So in Figure 10 at the bottom, you can see that uptake of the 6-month regimen has been really rapid since it was introduced in September 2023, and nearly half of the patients, 45%, were already initiated at that time, and it really increased a lot, and this was 88% in March 2025. So in Figure 11, you can then also see that the outcomes of the BPAL have been very good. So amongst the first 2,500 patients who started the 6-month regimen, 77% received treatment success, compared to 66% with the old regimen. That's very exciting. And bedaquiline is really what is the major impetus for the shortening for the 6-month regimen from 10 drugs for 2 years, so down to 6 months with only 3-4 drugs. So bedaquiline resistance is now, unfortunately, so this is resistance was first described in 2015, and it was really shortly after it got approval, and at the same time as used in South Africa. So the resistance came quite quickly, and it's an emerging growing concern in drug-resistant TB management. So in many cases, resistance emerges when regimens are poorly protected and when treatment adherence is inconsistent. So it's really critical that we protect this resistance. This study showed how the difference in the mortality, between bedaquiline and without bedaquiline in XDR patients and in MDR and resistance patients is quite a massive difference here. There's also some very good South African studies in Western Cape and KZN that showed about 12 and 14% of bedaquiline resistance. All in all, the estimate is about that 5 to 10% of rifampicin-resistant isolates are bedaquiline resistant in South Africa, and it can be more than 50% if there was interruptions in bedaquiline treatment with bedaquiline regimens. So it's important to remember that even though we have so much resistance, that most of them are still sensitive, and we should still use this, and it can still have a huge impact. And it's also important to remember there are very little resistance so far against predominant and linezolid. So, and the testing of bedaquiline is a bit of a problem. There's the genotypic and phenotypic results may not always align very well, and we're heavily dependent on targeted next generation sequencing in many cases. So the problem with one of the warnings with bedaquiline is still there is the QT prolongation. So there's a lot of follow-up of patients that's required. So so I've said most of this already, but let's just go to this itself. So in the guideline itself, there were quite a few changes into the of the definitions. And the most important is the rifampicin-resistant TB. It just means at least rifampicin, but it includes all these categories. And XDR is now at least rifampicin resistance plus one of the fluoroquinolones and either bedaquiline or linezolid. That is quite important. Pre-XDR is almost the same as before, and MDR is almost the same as before, but the XDR changed. And in the guideline, this actually referred in general to all of these. Okay, so there's no time for this. I think it's just important to know the BPL and BPL regimens is for, in general, is for everyone, except if there's some resistance to bedaquiline or linezolid or predominant or delanimate, or if there's XDR TB, or if there's severe extrapulmonary TB, and in children under 15 and pregnant women. They are not, doesn't qualify at the moment for the BPL and regimens. Everyone else get the long individualized treatments. Yeah, this is the new groupings. We always try to have all three in group A. We have bedaquiline, linezolid, and levomoxi is very different in the groupings from before. Group B is clofazimine and trazodone, and group C is all these old toxic drugs we don't, many of them we don't want to use. And a reason why we do not like following up on XDR, MDR, drug-resistant TB in private is because it's extremely expensive and no one wants to pay for that. It's really this weekly, 2 weekly, monthly follow-up with bloods and ECG and visual loss testing and questionnaires and pharmacovigilance reporting. It's really, really a nightmare. So most people do end up going to private or to public. Rifampicin monoresistance is relatively uncommon, but it's clinically still important. And in the end, we just treat it like MDR TB. You can see here for different provinces overall what is the resistance is between 1.1 and 3% of the TB is rifampicin monoresistant. Isoniazid monoresistance is much more common than many people think. It's definitely not almost drug susceptible. We shouldn't talk like that. It's more around 5 to 10%. A recent study here showed in Eastern Cape the prevalence was 11.6%, and yeah, that obvious treatment if consequences. It's important to always remember ARVs and IRIS, so that you don't start ARVs too soon. The lower the CD4, normally earlier you have to start the ARVs after you've started TB treatment. And in TB meningitis, you have to wait at least 4 to 6 weeks before you start ARVs after starting TB treatment. Otherwise, you get this immune reconstitution syndrome. So, inflammatory syndrome. So, for TB meningitis, it's extremely high mortality. Even with treatment, we still treat that with standard treatment regimens for 12 months. Steroids are always, almost always indicated to reduce inflammation, neurological disability, mortality. And most of these cases the drug-resistant cases have to be referred to the National Clinical Advisory Committee. And there's regional, provincial committees as well. And they will get at least 18 months of these regimens. DILI, that is a big problem globally. Around 11.5% of patients starting TB treatment get some form of DILI. There's a high mortality rate. It usually is within the first 2 to 2 weeks after starting treatment. The highest risk drug is pyrazinamide, then is isoniazid and rifampicin. Ethambutol is not generally hepatotoxic. They develop symptoms, then the liver functions go off, and then you have to stop all the TB drugs and monitor for 7 to 12 or 14 days to look for alternative causes, monitor liver function until they've normalized, and then you can reintroduce. And during that 1 or 2 weeks in Africa, we have this thing of a holding or a bridging regimen where we try to not take the TB treatment completely away, but we use non-hepatotoxic drugs, which include levo, ethambutol, and linezolid. And ethambutol is quite hard to get, and it seems to be there's a tender issue soon. So we'll see what happens there. There are very specific guidelines, and in the end, you bring back the drugs slowly. First isoniazid, and after 2-3 days, then you go first rifampicin, then isoniazid, then pyrazinamide, and then if you get liver function impairment again, then you have to stop that drug immediately, permanently, and then this is sort of what regimens you can go can often work. Let me not go into pregnancy now, but for children, this is a fantastic guideline. I won't say anything more, but it's really the treatment that this is very within a family context nowadays. In ICU, TB often catches us out. We don't think about TB with many patients in ICU, but so if the probability is high, rather treat, don't wait, do all the testing you can. When you start treatment, remember about IRIS and DILI, and also adrenal and hemodynamic problems that will develop. IPC is always important. The administrative controls comes first. The systematic screening, cough etiquette, those are the most important. And you need support from a hospital or healthcare facility, otherwise nothing will work. It's important that ventilation should be done well. I'll show you a picture about that now, and then you should remember about masks for staff and for any symptomatic patient. So here we can look at the flow, how you should not sit across the patient if the air flows in this direction, rather from you towards the patient is much better. And actually sitting just across the patient is not a good idea. You should rather sit on many people say sit on one side so you don't face the patient directly. And that's any patient who may have TB with respiratory symptoms. And then this work airflow inside the hospitals also should be important so that you don't have airflow from the patient's bed towards you, but the other way around, and there's no short circuit there. So TB preventative treatment. This is a very old picture. We just talk about latent infection, and that is a small percentage of people get latent infection after they have been in contact with TB. In South Africa,
Apologies for that. Just give us a few seconds. Hi, Dr. Ampi, we lost you again. Can you please just reshare your screen?
Okay. Is that okay?
Yes, thank you, doctor.
Okay, thank you. Almost done. So TB preventative treatment is something that really needs to be scaled up. You have to, before you can do that, always have to actively exclude TB first, the TB PCRs and X-rays and all that. And the regimen really depend on your age, HIV status, pregnancy, and also the antibody RAM of the index case. So just a quick word, there is some work done in what to do in resistant TB. Some studies have shown there's not much difference between when you use levofloxacin, and then there was a meta-analysis that said there was a 60% relative reduction in TB over 1 year after using levofloxacin for contacts of resistant, rifampicin-resistant TB. So this is something to watch this because the number to treat is quite high. It's for the 54 weeks you need to treat, I think, something between 18 and 115 patients. The next very big thing in TB was a TUT trial, and that was targeted universal testing for TB trial, and they based their testing on not on symptoms, because symptoms doesn't work very well, but rather on those who are HIV positive, who had close contacts within the last year or had themselves TB in the last 2 years and attended the clinic. They just tested them, asked them for sputum. Even if they can't produce, they just almost like made them give 3 ml of saliva, I think, and they tested that on TB culture and TB PCR. And initially I thought there was not much of a difference, but the secondary analysis showed that in the intervention clinics, they diagnosed 17% more people than in a previous year at the same clinic. So that was very exciting. And there was many offshoots of this study, many different groups we're looking at. And it's important now to just take a step back and to realize that that often that asymptomatic screening of household contacts is quite important, especially look at this study from end of last year. The main outcome is they looked at a few places, I think in Gauteng or in Northwest, where they did the investigation. The main outcome of the study was that 80% of TB cases among household contacts were asymptomatic, and more than 40% were missed if they just do X-ray screening. So, yeah, they did contact tracing of household contacts, and they did all this testing and saw even CRP and see what works and what not. And so this was quite exciting. Speaking of X-rays, the digital chest X-rays are very much at the forefront. So in 2021, WHO recommended that people over 15 years in populations where TB screening is recommended, they should you could use computer-aided detection software, AI, in place of human readers to interpret chest X-rays. And in a South African study, then evaluated all these different products in terms of sensitivity and specificity. And depending on how you set the settings of the instrument, you can say if you go for a threshold of 90% sensitivity, all of these, then you get specificity between 32 and 70%. Likewise, if you go for a 70% sensitivity setting, you keep it specifically around there, then in sensitivity is around here. So some of them were not doing well according to WHO standards, but the top 3 are really doing quite well. And we even have, since January last year, our own community-based TB screening guidelines for South Africa, and they target all these populations. Yes, with all the screening from a TUT trial and the X-rays, it's important. We don't really know yet who is the best to screen. So this is just the flow diagram for there. Just talk about vaccines. The BCG vaccine is still the only licensed vaccine for over 100 years. It protects against severe forms of childhood TB, mainly miliary and TBM. Only the worst forms, not all disease, and it's not reliable in adults. So, and it's still used widely internationally. This study from this month talked about, look at where the vaccine trials stand at the moment, and it's quite exciting. We have at the moment, you get different types of vaccines. So there's the POI is the prevention of infection, that's pre-infection. And then you get the POD is the prevention of disease post-infection vaccines, and you get therapeutic vaccines as well. And there are quite a number of these vaccines in the pipelines. At least 16 of them are currently, or at least 12 of them on clinical investigation. And the most exciting one, or the most further advanced one, is this M72 vaccine. And it's currently in phase 3 trials. They claim about a 50% efficacy in people preventing active pulmonary TB in latently infected patients who are HIV negative. So, and it lasted for 3 years, and they say it can maybe prevent 76 million cases over 25 years. It can prevent 8.5 million deaths over 25 years, and reduce healthcare costs by over $40 billion over 25 years if this vaccine turns out to be good. So this is really an exciting place. The replacement vaccines for BCG is the MTB-VAC and VPM 1002. There's no timelines yet, but according to the study, so if the trials succeed, then the first TB vaccines may appear at around 2028, 2030, and then wide rollout through the 2030s. So the WHO also recommends food assistance because it is the top attributable risk factor for new TB cases. That's not for globally. HIV is not the top, but it is in the top 5. So they say really food assistance is not that it's for prevention of TB treatment as well. But in Africa, it's quite different. HIV is our top attributable risk factor. So we have some different priorities here. Maybe secondly, alcohol and diabetes, smoking, and that. Undernutrition is 5th. So that's in closing. To say this is a modeling study that looked at over the next 25 years, what could be the potential impact and the cost effectiveness of different interventions on TB, and the short drug treatment regimens, the drugs that we're testing for all the long treatments had very little impact. That's now for Brazil, India, and South Africa to investigate. Nutrition had a big impact in India, and people testing in prison is a big thing in Brazil. But in South Africa, all 3 of them, the biggest impact is first is community screening, wide community screening, and secondly, vaccination will have the biggest impact. TB preventative treatment also a big impact, bigger impact than all of these other regimens we're using. So this is really, we have to keep this in mind. And we can say we have good tests, we have good and treatment options. What we need is vaccine miracles, and we need improved screening. Maybe we need tongue swabs, mouth swabs for people delivered at home and send in every year to screen, and then have vaccines to back it up with. So there's really been a paradigm shift in TB in the last few years, from symptom screening to risk screening, and from having an individual-centric approach to a household-centric approach. So please use rapid molecular tests early. Culture is still very important. Interpret resistant results intelligently, and prevention, infection prevention control, and nutrition are all part of TB care. Thank you.
Thank you very much, Dr. Ampi, for this informative webinar, and thank you everyone for joining us. Apologies once again for the sound. The webinar will be available on our YouTube channel as well, and we will reply to your questions after the event via email. Thank you everyone. Enjoy the rest of your evening.